head and neck cancer patients. So, as I said, there is no role as a curative intent in head and neck. Either it is surgery or radiation. It is equal in every stages. When it comes to T3, T4, radiation holds them high, or T4A, bone involvement, surgery is connected. But to enhance the outcome, to improve the disease-free survival and the overall survival, I will be giving something called concurrent chemoradiation. So, when radiation is given, I will be giving a small dose of chemotherapy, which will enhance the effect of radiation, and also because it's going to be a T3, T4 lesion, the chances of micrometastasis is more. So, when I give chemotherapy, it will be taking care of the micrometastasis which is in the body. So, usually we give 5 days a week radiation, and on the 6th day I will be giving a small dose of chemotherapy. So, this is what we call as concurrent chemoradiation. So, this patient I would be happy to give concurrent chemoradiation because N2, and this definitely will be a postpartum of invasion more than 4 or 5. Definitely I will be happy to give. So, when I come to have concurrent chemoradiation, I have choices whether I go with the traditional chemotherapy. The traditional chemotherapy which has been proven to be of better use is platinum agents, cisplatinum. The patient is not fit enough to receive cisplatinum, I would be going with the carboplatinum. And an addition of other molecules, because right now we have something called targeted molecules and immunotherapies all coming in. So the addition of all with the chemotherapy agents has improved the outcome.
Come to that scenario later for immunotherapy, sir. So this is what is the guideline. Adjuvant chemotherapy, there are mandatory indications. That is a positive margin, that is zinc on tumor, extranodal extension. These two definitely require concurrent chemotherapy without a doubt. All other indications are marginal. We look at the risk factors, the WPI, whether there is LVSA. Based on these markers and other high risk factors, we decide whether to give chemo as well.
What are those short forms you are using, sir? WPI, LVSI?
First pattern of invasion is WPOI. LVSI is lymphovascular space invasion. PNI is perineural invasion. Sorry, I probably should not have used these.
Yeah, it's like the tumor is started going into the nerves, so that
Perineural invasion, I guess.
So worst pattern, sir, how it is? What is the border of the tumor, sir? If the border of the tumor is like a pushing border.
So it's basically a pathologist will tell you the pattern of invasion is there. Whether it's a pushing border, infiltrative border, or a totally characterless border.
Few cells have started falling out of the border exactly, and sometimes these cells will be in big bunches. Sometimes these cells will be individual cells which will fall out from the border. So those are the patients like WPI 5 and all, where even a good oncologist may sometimes land up with a close or a positive margin. So it's not always the oncologist's fault, but WPI is like when we are getting from good border to a bad, worse border. And now it is a protocol that we have to report WPI in our path reporting for all oncologists.
This is a last case for the day. So this patient was not willing to come to the OPD. He was got to the clinic by his wife. You know what the wife told me? Sir, எப்பயுமே வாயில குண்டு வச்சிருப்பாரு அந்த வெத்தலை பாக்கு டொபாக்கோ எல்லாம் வச்சிருப்பாரு இப்போ வைக்கலாம் கூட அவ்வளவு பெரிய கட்டி இருக்கு. So that is what made her bring him to the clinic. So what is obvious is the large growth in the buccal mucosa, and you can see that the skin is involved here. The stretched shiny skin, edema skin is there, and the picture may not be very clear, but actually this sort of edema is extending up to the zygomatic region. So this sort of a patients come to you. These are not unusual situations. Please do not think that these are all unusual situations. They are run-of-the-mill situations. Every 1 in 10 patients oral cancer is like this. And this patient comes to you, Shubhra. We know the usual stuff, biopsy we have done the imaging, all that stuff. What would you do?
So again, after imaging, main thing we as surgeons will check for operability. For us, main thing is that, when we are seeing the tissue, not forget the 2 dimension which we see in the mouth, the buccal mucosa, alveolus, lower alveolus, skin, all these are easily removable. These are not our issues at all. The third dimension is the depth dimension which is not visible to the naked eye, which is always seen in the scan. if we are able to get a margin there, in the sense that if we are, the tumor is already involved in the muscles, it is pretty obvious, that is a masseter or a medial pterygoid. But if we are able to get a margin on that muscle superiorly, means either we are able to get the muscle from the skull base, that surgically is possible, but the tumor should not have reached there in the scan. If that has happened, then we are going to get a positive margin in depth, and that is not a surgical candidate at all for us. But then we will send the patient that side. But if we are able to get a negative margin, that means that part of the muscle is not involved superiorly and only inferiorly is involved, we will clear the muscle also. Forget the skin, everything we can clear easily. We will even clear the masseter from the zygoma, the medial pterygoid from the pterygoid, and sometimes even lateral pterygoid from the skull, that is sphenoid, and get all the muscle down with the tumor. So if this is not possible, we will do a tumor mode from that side.
Basically, what she's trying to say is the infratemporal fossa. The infratemporal fossa, we have category of involvement, category 1, 2, and 3. And the category 3 is a high ITF, where it has gone up to the sigmoid sinus. That is a patient who is technically unresectable. That is a patient you should not resect. If you leave behind tumor, gross macroscopic tumor, and do the resection, leave behind, I left only 1 centimeter of tumor, it is as good as taking a 1 centimeter biopsy. So you may as well not do the surgery. Doing a palliative resection is worthless because the tumor will come back in no time. Okay, these are the patient comes, we are very clear that the edema is there, stretching out to the zygoma, makes it clearly unresectable. These are patients, we will only say unresectable. We are not saying not treatable because we know we can downsize. For that, we have take the help of our medical oncologist. Suresh sir, what would you do?
So we have seen that skin. So skin is stretched, which means there is a lymphatic infiltration of this. So however you are going to do the surgery upfront, there will be always a positive margin. So to come and reduce the morbidity, so we give something called neoadjuvant. Adjuvant means after the definitive treatment, if I am going to give any treatment, that's called adjuvant. Here, the definitive treatment is going to be surgery. So I am giving a treatment before the adjuvant treatment. So before the definitive treatment. So it is called neoadjuvant. So earlier we saw that this concurrent chemoradiation. After surgery, when we give radiation, it is called adjuvant. I am going to give a chemotherapy which is before the definitive treatment. So it is called neoadjuvant. So that is how we always define. So because when I get
concurrent or appetizer, sir. Neoadjuvant is a strong dose.
So neoadjuvant, I will be giving a combination. When I say concurrent chemo, I will be sticking to one chemo regimen. Whereas chemo medicine, whereas the neoadjuvant, I might be giving 2 or 3 combination because I need to have a rapid reduction in size, and so that the surgeon will be taking it as early as possible. So I will be giving something called TPF, that is the taxane, platinum, and 5FU based regimen. And unlike where other disease like lung or breast, where we give 5 cycles, 5-6 cycles, in head and neck, it always we go with from the 2nd cycle onwards. If the patient is fit enough to undergo surgery, we will send the patient. There is no timeline, 3 cycles, 4 cycles, no. From 2nd cycle onwards, the patient is fit. The surgeon feels the patient is fit enough for a good adequate margin, we will send the patient. So this patient will be fit for a neoadjuvant treatment.
When do you use neoadjuvant chemotherapy? In short, the masticatory space involvement, tumor extending up to the condylar notch, and the sort of edema that we saw going up to the zygoma. It's not a small lesion in the skin. The skin involvement which is close to the tooth socket or very close, that is not we are worried about. When we see this sort of edema, we have to be very careful because the lymphatics will be teeming with cancer cells. You get a margin positive, that the surgery becomes worthless. Now, the question on whether neoadjuvant chemotherapy helps in organ preservation, to give it a short answer, definitely yes. It may not improve the survival assets. Whether you give it neoadjuvant or adjuvant, the results are going to be same. But you will make an inoperable tumor operable and thereby make the patient survive better. If you don't do the surgery, the patient is going to do very bad. So how do you do surgery in these patients? Make them resectable by giving chemotherapy, downsizing the lesions, and by doing that you are going to increase the chance of the patient completing the treatment. Now there are some criteria on when you will call as unresectable. Certain examples will be for a buccal mucosa when it is going beyond up to the level of the zygomatic arch, a tongue primary which has gone below the hyoid bone, tumor originating in the tongue going up to the valvula, infratemporal fossa, high involvement, or where you can't give a negative margin. This is the criteria that we call as inoperable or unresectable, where we will consider some form of chemotherapy upfront. To summarize, in unresectable situations, induction chemotherapy really works. This will make the patient undergo surgery. Now, this is the head and neck cancer guidelines in systemic therapy. Suresh sir, you worked on the options, the treatment approaches in these situations.
So, systemic therapy, we wanted to be neoadjuvant, T4 or metastatic rectal cell. So, neoadjuvant, as I said, we'd be happy to give chemotherapy alone, but nowadays we have developed more and more into targeted and immunotherapy. Basic things about chemotherapy is that you have more and more side effects. It all depends on the cell cycle. The surgeon does not need to know whether there is a cell cycle happening or not. He puts in a knife, whatever the tissue has got different cell cycle, he removes it. But for radiation and chemotherapy, we all depend on the cell cycle. The combination of chemotherapy, why we need to add three chemos or 2 chemo agents is, each one will be acting in a different part of the cell cycle. So there will be a enhanced cell kill. If I am going to give one medicine, it will be killing the cells in one part of the cell cycle, whereas the other cells will accumulate and then they try to develop a resistance. If I combine 3 or more, the resistance will be overcome, and even tissue, there will be in a different, say sometimes the tissue will be G0, some will be S, some will be G2, some will be M phase. All will be getting killed with the combination of chemo, and there will not be any overlapping toxicity. Now we have something called targeted, and we are rapidly developing on the origin of the cancers, whether there is any genetic mutations coming up, is there any targetable genetic mutations which can be hit upon. So basically, this head and neck cancers can have EGFR, that's the epidermal growth factor receptors, or VEGF, vascular endothelial growth factor receptors. So these can be attacked with the targeted agents along with chemotherapy, so that the response is more. The latest is immunotherapy. Immunotherapy is where the cancer cells develop because our immunity